Hi, this is Brian Kim. I'm going to share with you my standard Gundersen flap technique. This is a great procedure to deal with surface-related pain syndromes in eyes that have poor visual potential. So this patient has band keratopathy with a corneal pain syndrome. I'm going to first place a traction suture at the superior limbus, and then I'm using a crescent blade to deepithelialize the cornea in the area of the band keratopathy. I'm placing topical EDTA on the area of the band keratopathy and letting it soak. I go ahead and rotate the eye downward and place a caliper measuring about 13 to 14 millimeters posterior to the limbus. Again, you want a couple of millimeters of it more than the corneal diameter. I'm placing subconjunctival lidocaine, making sure I'm just underneath conjunctiva and splitting the conjunctiva from the underlying tenon's capsule. I like to start posteriorly in size and stay circumferential and parallel to the limbus. I'm using conj forceps to hold the tissue as I go ahead and cut. Again, I'm trying to separate the conjunctiva from the underlying tenons, and just using blunt and sharp dissection, you're just going to go ahead and continue to carefully remove and again lyse the conjunctiva from the underlying tenons. This patient thankfully has pretty robust conjunctiva, and again the traction suture is very important to help give me excellent exposure. And again, you're trying to tease the conjunctiva off the tenons in the area of dissection, but you're going to continue to one side and then the other side. The more you dissect, the freer the flap will be to place on the cornea. You want to go ahead and perform a 360-degree peritomy to help separate the conjunctiva from the underlying tissue. After the EDTA was placed on the area of band for several minutes, I go ahead and try to tease off some of this stubborn calcification using the crescent blade. Due to the time element, I went ahead and sped up that portion of the surgery. I'm going to direct my attention towards the flap and try to separate the flap completely from the underlying tissue. It's important to get a flap as thin as possible, and that begins first with injecting the lidocaine just in the subconjunctival space, and then sharply and bluntly dissecting it from the very beginning and following that plane as you go across. And again, if you buttonhole, that's perfectly fine. From a cosmetic standpoint, you want that tissue as thin as possible so it's not as obvious that there's something on the cornea. Once the flap is free, you want to disengage your traction suture and pull the traction suture away, and then go ahead and place the flap onto the cornea, and you're bluntly stretching it and separating it to make sure it's got good coverage over the cornea. You want to make sure your cornea is completely deepithelialized before you place the Gundersen flap. I use adovarchal suture and place mattress sutures to fixate the graft onto the patient's episclera. And you want to start on the episcleral side so that the knots will be buried. So this part, you're going to just see the adovarchal suture being fixated to the episclera. Again, using the mattress technique, it helps really secure a wider area of conjunctiva to the underlying episclera. Placing another mattress suture in a different sector. You want to make sure you get to the episclera first, and then you get a bite of the graft, and then a graft on the other side, and then you go ahead and suture it down. So just going around circumferentially, continuing to place mattress sutures with the vicryl, and again starting with episclera, taking bites, and then through the graft, and then tying it down. This helps bury the knot. You get good coverage without using a whole bunch of suture. This is the, I think, second to last quadrant here. Again, taking a bite of episclera and then part of the graft. You're going to turn the suture around and then take a bite of the other part of the flap there. And then go ahead and tie it down. And you can see the graft is fairly thin, which after the blood clears this patient should have a nice cosmetic result. And more importantly, the pain syndrome will be resolved. So there's a final suture, again going through the episclera and then passing through that portion of the flap, and then going around and capturing the other side of the flap and then tying it down. So this is an excellent procedure, again, for eyes that have poor visual potential but have corneal pain syndromes. This really helps save the patient from having an invasive procedure such as an evisceration or nucleation. It's, again, done correctly, can have a really nice cosmetic result, and you really spare the patient from a very traumatic procedure such as an evisceration or a nucleation. I like to inject subconjunctival antibiotics and steroid at the end of the case, and this is my procedure for the Gundersen flap. I hope this was helpful to you, and thank you for your attention.